reflects the rapidly evolving landscape of respiratory medicine and the key intriguing theme of Conshwas 2026.
Your inspiring opening remarks. We begin our scientific journey with the infection session, focusing on contemporary perspectives in community-acquired pneumonia. This segment will be chaired by Dr. Kohina Roy. May I request Dr. Roy to kindly take the chair and guide us through the session.
For the 3 days. So again, you can
The first new generation macrolide in near about 3 decades here to fix the CABP mess. So nafitramycin arrives with an impressive resume. Broad coverage for nearly entire spectrum of community bugs, strong lung penetration and just a 3-day regimen. In a world where CABP has become more complicated, this feels like it is recommended for adults only. Yes,
with pneumonia in his family. The patient is sick, so will you be able to, will you have the courage to leave the patient on a single therapy? No. So that's the inpatient work.
Yes, I have shown in my slide that it can be that one of the use that we can add this as a add-on to the injectable in seriously and critically ill patients.
In the last year. So please remember these facts because this will be handy when we go on and try to manage this patient. So this is how we diagnose, this is 2026 guideline, how we manage and diagnose COPD and the basic test is a spirometry. And spirometry, I think we need all of us need, which discipline you. There's a combo arm and better outcome in every respect. And even the mortality is better.
that paper says that if a patient is using inhaled corticosteroid, there is an increased chance of pulmonary tuberculosis. So
Or
that's
reactivation as well.
Reactivation.
Or reactivation as well. So India to you cannot prescribe. We should stop using ICS altogether. So thank you very much. Thank you.
Thank you, Indra.
Thank you, sir.
This is the reason. Now this is the old guideline.
Conditions are different. So that doesn't take away science from science. So science remains science. So I'm supposed to talk on optimizing management of severe asthma with the use of biologics.
That's my question. What I'm saying is for us inferior mortals, we have the next best option, the values and that is what the guidelines say as well. And what you are saying is this should be done. Yes, possibly yes.
Even they tend to force the most of the effects. So we are having import, export, good qualities of things, but you cannot exchange because one is down, one is up. That's the concept of reverse ventilation gradient. There are also relations between obesity, asthma and bronchial hyperresponsiveness. One thing I would want to highlight because this is very important because pulmonologists, ENT doctors use corticosteroids. In obese people, the problem that we face is that there is less response to glucocorticoids.
Can give rise to what we call a chronic inflammatory state. The chronic inflammatory state can actually worsen the airways as well as cause eosinophilic recruitment and airways inflammation. So in that way also the GLP-1 RAs are also important and they can not only reduce the fat volume when the upper air is fat and the mechanical constricting effect, but it also gives benefit with the chronic inflammatory state. In that way the airways function can improve. So I put this session open to question and answers. And if there is any
COPD and obesity is not that much common that we encounter. Rather we get other way recommendations of GLP-1 agonist in COPD, is it only related to weight loss, or that there was the pointed out that anti-inflammatory effect?
Yes, anti-inflammatory. There was one slide, I skipped that. There was a round slide where I mentioned, it was mentioned about thymocyte 1 response, eosinophilic recruitment, all these things. But if you look at the guidelines where these classes of drugs are approved, they are mentioning mostly OSA.
Know that allergy disease on a global scale is just rising in its incidence and prevalence. Be it in the 2200 BC in Egypt,
We now move into the first part of our immunization session, addressing the growing importance of vaccination in chronic respiratory diseases in adults. This segment will be chaired by Dr. Madhu.
So the data shows that globally COPD affects nearly 10% of the adults over 40 years, rising to 20 to 25% in those over 70 years old. Asthma affects individuals all ages with a prevalence of about 10.4% among elderly.
Lost productivity and deaths worldwide. Symptoms of high fever, body aches, fatigue, sore throat, cough, headache, chills could be any viral infection. Why is it serious in adults? Cold. It does affect the whole body. It affects the lungs, the heart, the brain, the immune system. It may lead to viral.
So with this clinical background, follow, if you do not have facility for further investigation, is this history sufficient to diagnose asthma? Or in other words, do you consider that asthma is a clinical diagnosis?
Still now we can't say this is asthma directly. Peaceful means still we can put it on the chart, on the diagnosis.
So this is moderate to severe and persistent symptom. According to the area guideline, we should start with inhaled corticosteroid only, or intranasal corticosteroid only, or intranasal corticosteroid and that adrenaline.